Hi, everyone. I'm Tony Latai, President of the SFPM, and welcome to our monthly seminar series. This is the November seminar series, and we will shortly have a presentation to be introduced by Keith Ligon. I just want to give everyone a reminder to stay involved. Let us know how we can help you. And you will be seeing a communication the next few weeks. As a reminder, is to re-up your annual registration as members, your annual membership as the SFPM. Just a reminder that annual membership is free for trainees, and we may be able to offer. We're seeing if we can encode this sort of multi-year memberships to decrease just the administrative nuisance of annual membership renewals. So I'll also just mention, this is very selfish of me, but I will mention that I am hiring a postdoc in the functional precision medicine world. So if you know someone who would be interested in such a job, please just contact me directly. With that, I will turn it over to Keith Ligon to introduce this month's speaker.
One deviation from that, Tony, is there's the ACR meeting. Is there the abstract deadline is super close, right? For the membership, if they wanted to attend that one in Boston, is that right? Or maybe it's today.
Yeah, thank you very much, Keith, for that. Yeah, we're right on the cusp of whatever needs. I think it's the February 15th. Sorry, November 15th. I think it's this Friday is the abstract deadline. So please, if you want to attend, and I encourage anyone on this call would probably get a lot out of that meeting. But if you are interested in attending, get your stuff in, and we look forward to seeing you here for what should be a great meeting, combining functional and genomic precision medicine leaders in the same meeting here in Boston next March. Thank you, Keith.
Yeah, and great. And now to the main event. Just my pleasure to introduce Dr. Long-Sheng Liu. He's a radiation oncologist and associate professor at Taipei Medical University, where he's the deputy director of the research center there for translational cancer medicine, based on his extensive expertise in that area. He actually did postdoctoral training at MD Anderson Cancer Center, where I trained as well. I don't know if we overlapped, actually, Long-Sheng in that period, but and his research now is currently focused on translational radiation oncology, specifically personalizing cancer medicine and diagnostics. And he's made a lot of progress in microfluidic circulating tumor cell technologies, and really challenging but excellent work in looking at isolating cells from blood and circulating tumor cells. And just generally, he was interested in sharing his personalized cancer treatment expertise today, and we really appreciate you speaking and look forward to your work. So if you can take it from there, that would be great.
All right, thank you, Keith. Good morning, everyone. Thank you, Keith, for a very nice introduction. And today I have something like a 30 or 35 minutes talk, and hopefully I get it done on time, and so that we can have more time for discussion. So let me share my screen. So can you see my presentation now?
Perfect, yeah.
So is it moving? All right, good. So so today I'm going to tell about our experiences during the past 4 years on doing liquid biopsy and to correlate the genotype-phenotype findings in clinical scenario. So I have some disclosure. Currently, I am the adjunct chief medical officer of the startup Cancer-Free Biotech, which tech license my technologies. So I think this is a major disclosure here, and others, they are just a general consultation to local pharmaceutical and biotechs, and lecture royalty from international pharmas. So I think all our audience understand the need that we really need to push our technologies into the treatment scenario, so that we can take care of cancer both in the primary prevention, secondary prevention, and tertiary prevention settings. So just like Dr. Vince DeVita in his autobiography, The Death of Cancer, mentioned that the roadmap toward cancer cure, we don't really know the map, but we have done so much that the mortality decreased by 30% during the past 20 years. And hopefully this slope is going to drop continually with even better slope. But I think with that, we need a better tool to help us to do primary and secondary tertiary prevention and match our pharmaceuticals to the patients who is really in need. So this is where precision medicine comes in, that we are matching the currently available drugs to patients that really needs it at the right time, so that we can decrease cancer-related deaths either early on or later in the developmental roadmap. So if we understand that cancer is actually a genomically driven diseases, and Bob Weinberg told us like 10 years ago, you can categorize cancer-related genes into functional categories. There are roughly 400 of them directly related to cancer progression and metastasis. And each of them, you probably have 1 to 10 drugs that is either on the pipeline or is already on the market. But unfortunately, those things came in a very slow penetrance. A percentage of each genetic driver in specific type of cancer is very low. So that unless you have a holistic way to map the whole genome, otherwise this genomic information helps very little. But then we realized that after anecdotal success in EGF targeting therapies and others, we realized that one gene, one phenotype, one disease is a rare exception. Actually, the correlation between continual growth and the genetic alteration is very complex. People are trying to model it, but I think this model will go on for the next decade, and we will not have an answer. So the real thing is that now we understand that cancer has its genotypic roots, but that it is very challenging to directly infer genome sequencing information into biological behavior prediction. Then we need a better tool to phenotype the cancer at the individual resolution, even at the each disease-specific resolution, so that we know exactly what is going on in each patient, so that we can design for the best pathway for the treatment. So this exactly is what has been done during the past 20 years. We started by in the European, and then it's in the States, and now it's all over the globe that people realize that gene sequencing is actually useful. And how it is being used is that you need to sample the tumor and get the most information out of it. Either it is a gene sequencing, RNA sequencing. You can do a little bit organoids. Now people are developing organs on the chips. And with the advance of molecular imaging and theranostic, now the radiomics comes into play. You need to integrate all those information from the latest relevant patient samples, and then try to use artificial intelligence to help us shortlist the potential actionable strategies. And you have a specialist that is experienced in reading those information and treating patient accordingly. That is a molecular tumor board. I think this is a very useful system to guide us through the pathway of to bridge the technology to the real world outcome. So fortunately, we are able to initiate this mechanism since 2017. So 7 years after now, we now know how this works in Taiwan, and we are building up infrastructure as well as delivering the services to the patients, and we are measuring the outcome. And I don't have the outcome data today, but to very briefly mention about that, in Taiwan, in our Taipei Medical University, we routinely do that for patients with challenging diseases that has been refractory and it was not able to enroll into clinical trials, and they were referred to molecular tumor board, and we provide sequencing and LDT-based multi-omic tests, and we try to interrogate the results and provide treatment recommendations. And the success rate of the treatment is roughly 50%, and some of the patients survive really long, and their progression-free survival 2/1 extend more than 3 or 4 folds. I'm going to show some of the cases later in the talk, but I mean, the message is that yes, this approach actually works in Taiwan. And but we do see there are some challenges. For example, the static friction of the whole process, as has been evidenced by NCI mesh, it is a sampling failure. It is very challenging to sample the latest tumor from those patients with late stage of diseases. And even you are able to sample that, like 10% to 15%, it is not possible to get a good tumor for you to get any sequence out of that. So this has to be solved. And there are many advances in the technology trying to solve it. And I think one of the solution is to sample the information, cancer-related information from biological fluids. The reason is very simple, because cancer kills us 90% by metastasis processes. And they have to metastasize in this highway, the blood or lymphatic highway. So if you can intercept them in the highway, then the most relevant information is all out there related to disease progression is all out there. So although conceptually it is easy, actually more than 100 years ago, it has been proposed by Stephen Paget. But it is the technology only evolved so that after 100 years, now we are able to analyze those information at a personal level in our daily practices. So information inside those liquid basically contains a lot of things. And what we can analyze now probably include the DNA, RNA, tumor cells, or even organoids. And the challenges associated with these analyses I listed here, but basically the challenges focused around 3 dimensions. First, it is about the low concentration. Second, it is the question regarding the tumor specificity. You got some DNA, you got some RNA, even you get some cells. How do they relate to original cancer, and how do they predict the outcome? So the first thing you can do that by massive sequencing and by comparing to the original tumors. And you can do that in the study population. And from the study population, you establish the confidence level, and then you apply to the real world. And the later part, how it is relevant to a disease progression, you measure basically through the molecular tumor board-like mechanism. You measure the outcome based on the recommendation or findings you have, and you carefully document that so that you realize that the utility of this analyze. And even more, now there are people getting to know that those cells, they actually self-organize just like the developmental process from the stem cell. They organize into small clusters of multicellular structure. You can call that organoids, or I mean, whatever you like to call it. Initially, we don't believe it is ever existent in the bloodstream. But then very quickly, we realize that it is because our technology to get those cells, we filter them out in the very first beginning. So the lossless technology, after they are being developed one by one, and we start to see that this circulating multicellular structure in the blood actually is very prognostic, and it may even be predictive in some of the scenario. And today I'm going to share some of our findings and experiences in the circulating tumor cells and organoids. And I don't need to repeat this again. Basically, circulating tumor cell is a fugitive of the cancer metastasis. And the problem is that the actual cancer initiating cell in this highly homogeneous population, heterogeneous population, is very rare, and they look all the same. So unless you can characterize them functionally, for example, in the animal research, you do the xenograft and you see if they grow. Otherwise, it is very challenging to tell which one actually is a cancer-initiating cell. We know they are there, but we don't know how to pick them up. That's a problem. So you need actually technologies to somehow to analyze them. Initially, people try to count them. So there are numerous technologies. Most of people here, we know cell search, and there are other cell search equivalent technologies, but I think the message is the same. The number of the cell actually correlates with the stage, correlates with the outcome, and it applies to many different solid tumors. But unfortunately, the numbers, although they are prognostic, but they are not predictive. whatever you do after you see this miserable population, actually, whatever you do, they remain in this pathway. So we need more information out of that. So I think my colleague, Professor Fan Gangchan, who used to be trained in UCLA and in microfluidics, he came back to Taiwan and we worked together to develop some technologies. The idea is to use this lateral gradient strain guidance microfluidic phenomenon, try to do a automatic blood smear, very nicely smear the peripheral blood molecular cell into one layer, so that we can we can use automatic microscope to count the number of the cells with several fluorescence markers. So with this technology, basically we do not pre-select. We do not select based on size, molecular sieve, or surface charge, or anything, or the presence of cancer antigen. We just simply layer them and detect the immunofluorescent defined population. And then we very quickly realize that the number probably is not the most important key factors associated with the a stage or the outcome, but actually it is a number of polycellular sphere. At the time, we call it CTC cluster. Not only they can find out the population, this is a colorectal cancer case study. We analyzed more than 150 patients with early stage colorectal cancer. We followed them for at a median time of 7 years and documented recurrences. And people who experience the recurrence, usually they have a high CTC count and cluster count, as well as high CA level. And this is the time we realize that in our system, we can identify clusters rather than individual cells, and they really matters. And then we try to see if we can get functional information out of that. We are not the first in the world that is doing it. Dan Haber in Mass General has done that and has published in 2014. The concept is that you can use the microfluidic technology to isolate certain tumor-initiating cells, and in hypoxic environment and in growth factor enriched media, you can expand them into clusters. These clusters, they grow, and so that you can profile them genomically and pharmacologically. And the agent you identify will be very useful in the xenograft experiments. I mean, this is all very impressive. These are all very impressive data. But the problem is that the success rate from patient blood all the way to this stage to profiling is very low. It's 30% according to the publication. And the time from here to here and approved in animals, it takes 6 months. So if we want to apply that to the clinical scenario, trying to use the easily available information-rich blood sample to give us a guidance on the personalized or functional treatment, we need to accelerate the process, and we need a much, much higher success rate than 30%. And luckily enough, and when I came back to Taiwan from Anderson, and I was lucky enough to join the Biomedical Engineer College, and I have a colleague in biomedical materials and blood products, and I have a strong group of cancer doctors. So we work together, and we use the system we call binary colloid crystals. And basically, these are self-organized. We have 2 polymers. They self-organize into pore-like structures. And we optimize the pore-like structures that cancer cell will expand upon it. So the original version that George developed was used to selectively enhance pluripotent stem cell growth. So we modify the composition of the plastics, and we modify the manufacturing process so that we identify one of them that is especially good in growing cancer stem cells. And we actually document that the cell cluster we get actually contains stemness, and if you inhibit STAT3 with nacabulcacin, you wipe out all of them. So this is a very nice stem cell enrichment tool, and it works for most of the patients we look for. So we started this collaboration back in 2017, and the first patient we were able to have our blood sample tested. Actually, she had a rare disease that is called aggressive fibromatosis. It is abnormally proliferating fibroblasts invading the local structure. So by definition, it is a benign disease. Those fibroblasts did not transform, but the behavior looks like cancer. They invade, they grow, they invade, and they sometimes they even metastasize to distal organs. So this is a meso. I mean, this is fibroblast is a mesoderm, and this is the local disease. It is a benign disease. So originally, we do not expect to get anything out of her blood, but because her refractory disease course and she suffered a lot, she cannot use her right hand, and there was a lot of pain. So I enrolled her in the study when I was providing palliative second round of irradiation. But out of surprise, I saw a lot of tumor spheres growing out of that. And so we think about testing every single agent that was reported in the literature that was useful to treat aggressive fibromatosis. And out of them, many of them are chemotherapeutics. But this agent, tamoxifen, has a very good growth suppressive functional characteristics. And it has been reported in the literature that 30% of the patients with aggressive fibromatosis will respond to tamoxifen. There's no predictive factor. The only predictive factor is that they are all women. So this lady, I think, during her courses of 4 years, nobody has mentioned this to her, and it hurts nobody by having a tamoxifen. It is a very affordable drug and very low toxicity. So we started the medication on her based on this literature data and this finding. And impressively, her symptoms went away in 2 weeks. And when I was providing palliative radiation, I saw her hands regaining function, which I didn't see in the previous course. And she maintained on tamoxifen for up to now. It's been almost 7 years, and the disease totally went away. And the tumor shrank. There's only residual scar, and the neurological defect was completely recovered, and there was no disease throughout her bodies up to say last month. So this is a very unique evidence that you see some experimental finding, you apply that to a human sample, give you a biomarker, and this really works very nicely. And similar things happens again and again and again in 2018. In 2018, while the technology is still early, there are 4 patients with late-stage diseases. We were able to get similar information and provide relevant treatment out of no options, and we all see very significant responses. Then we know this is something that we have to move on to see whether or not we can scale it up and develop into a personalized treatment strategy. And then this is by 2021, we interim summarize our success rate. So I think the most important message here is that the biliary colloid crystal process, and from the peripheral blood molecule cell really is working very well. We have more than 90% of success rate in patients with all kinds of different metastatic tumors. And out of surprise, even patients with CNS tumor, we can also get GFAP positive cells out of their blood. And then most of the tumor cells, they retain the original surface marker characteristics of the original tumor. And functionally, we try to correlate the drug sensitivity data to their treatment outcome. And we get very nice correlation. Initially, we do that in small cell lung cancer, which has the highest count of circulating tumor cells we knew at the time. And we realized those tumor actually, they can grow into xenograft, and you can sequence like what Dr. Haber has done in Mass General. And we functionally characterize and correlate to clinical responses and realize that this is predictive of the responses to platinum and ifosfamide, which is the standard treatment, chemotherapeutic treatment. So I think we are among the earliest group that is able to get circulating tumor clusters and test them with anti-cancer drugs in the literature. But unfortunately, these patients, we only have very limited options, cytotoxic options to treat them. So we kind of stop here. We don't know what to move on next because these treatments, they are useful initially, but then very quickly they become refractory. But then we move on to other tumors like pancreatic tumor, to sarcoma, and to challenging pediatric oncology. And I think the common message we found is that in this challenging context, if you have an organoid drug sensitivity profile, you are going to enrich patients who is going to respond to your treatment options and with currently available drugs. And in the complex scenario like in sarcoma, especially in angiosarcoma, we are able to enrich a population that has responsiveness to pazopanib, which is a national health insurance reimbursed biologically targeted therapy. And so I think this allows us to select for patients who will respond in this scenario rather than giving every single patient with angiosarcoma this agent, because I mean 70 to 80% of them is not going to respond at all. So when we incorporate drug sensitivity into the algorithm, we increase the predictive odds ratio usually by 10-fold. Usually by clinical scenario, we have a predicted odds ratio of treatment response 1 to 2. But in this case of sarcoma, it's 12. In the case of pancreatic cancer, it's 17. And in the pediatric oncology, because of heterogeneity of the disease, we don't really have an odds ratio rate yet. But I mean, we have a cutoff of 14% of the viability kill that is going to give you a statistically meaningful responsiveness of the treatment. So after having looked at the growth statistics, I think this is a very interesting representative case how this is used in our now in our molecular tumor board. So this is a baby who was found with hydrocephalus in gestation. So the neurosurgeon decided to do a tumor biopsy once the baby was delivered, and it turns out to be high-grade glioma. So in this very unique context, they started chemotherapy, which is a standard treatment for this baby. But unfortunately, the disease progressed, and actually the baby was never able to went out of ICU and at the time. So at 3 months of life, the tumor increased by 224% in volume, and out of desperate wishes, the family asked the neurosurgeon try to do whatever that is possible. So that is when we have the chance to access the tumor sample again after the debulking. And when we have the tumor sample, we also sample the liquid biopsy to get circulating tumor cell from the blood and trying to do drug sensitivity screen. So it turns out that this tumor, the material we get, the tumor as well as the circulating tumor cells, they do not respond to the chemotherapeutic agent that was given at initial in the treatment regimen. But when we do genetic analysis, we realize of the debulking material, we realize there's a SOX5-ALK fusion alteration in this tumor. And this is a very interesting finding because ALK fusion predicts responsiveness to a series of chemicals that is effective in treating lung cancer with this genomic information, alteration. And the lorlatinib, one of the series of the chemical, is especially good in CNS penetration. So at the time, we faced a choice that you have the NGS information tell you that there's an actionable mutation, but it was only reported in adult lung cancer. Can you do that in pediatric population? So then we submit the cells to cancer drug sensitivity, and then we realized that lorlatinib actually gave the maximal suppression among the drugs we tested. So our pediatric oncology, Professor Yanling Liu, started this lorlatinib to the baby out of compassionate use program. And the baby, after debulking, the tumor shrank. The baby was able to go out of ICU, go home, and now the baby, the boy is 3.5 years old, and there's no perfect. This is the image at 10 months, and at 3 year old, there's no tumor regrowth, and the neurodevelopment is normal. He is now in the kindergarten. And because of there's some metabolic side effect from lorlatinib, now the boy's growth percentage is on the 97 or 98 of the growth curve. So I think this is a very happy story, and it demonstrates the power that when we have the organoid and the genotype together, very likely if you have a signal that can be confirmed from both ends, very likely you are going to have a treatment success out of that. And we not only see that in the pediatric brain tumor, we also see that with sarcoma. We also see that in pediatric brain tumor, in pancreatic cancer, in refractory colorectal cancer, in breast cancer. So it appears that genotype-phenotype correlation is actually a very important message to match patient to the existing off-label treatment or in-label treatment. But when there are so many of them, you need to find the one with the best chance, and then you have a genophenotyping altogether give you the best bet. And this is a case we found in lung cancer. This is an old lady who is really a fighter. She had the initial disease of lung cancer 2004, and after 2 rounds of recurrences, the last recurrence happened in 2019. And then by the time she was 79, and she was too tired for another round of chemotherapy, and her son suggests to do the sequencing, and sequencing get nothing out at all. So we are profiling her tumors to a wide array of drugs that can use to be treated to treat lung cancer. And surprisingly, we see quizartinib has a very impressive tumor suppression capabilities. And then we go back to the first round sequencing data. There is no information regarding ALK rearrangement. So, and because it was 3 years later, the foundation was available. So we submitted for another foundation assay. And at that time, the assay came back that in the sample of 2017, there actually is c-MET exon 14 skipping. So although there's no mutation or rearrangement in the ALK, there actually is c-MET exon 14 that correlates to this quizartinib. And then we started her on this medication, and her disease was very well controlled until COVID. And after she got COVID, she passed away very quickly. So this is another story with EGFR mutated patients with leptomeningeal seeding. The same thing happens again. We see the EGFR, and we dose the tumors, and the tumor, interestingly, respond only to the double dose osimertinib, but not the conventional dose, which correlates to the very important trial, Blossom trial, conducted by Dr. Jason Yang in Taiwan. Now the double dose of osimertinib is becoming one of the options when you have this late stage of disease, leptomeningeal seeding. And I believe this is the only treatment for cancerous leptomeningeal seeding that you are going to see neurological recovery. And it actually is, it happens in this case that after we see this, we convince the patient to start double dose osimertinib, and the lady was able to go back to her garden again. The response lasts for almost 2 years until at least COVID hit again. So COVID actually takes its toll in oncology patients in Taiwan, as we have experienced. But I think, although I'm showing you successful stories, there are sad stories, and this roadmap to precision medicine is full of surprise. For example, this is a gentleman with gastric cancer and carcinomatosis. So we think we may help them, so we do a profile. And the profiling, we came back with 2 candidates. One is mitomycin, and the other one is thalidomide. in Asia, especially in Taiwan, we have a lot of experiences in treating late-stage gastrointestinal cancers with thalidomide, and this appears to be a very safe option. So because this gentleman is experiencing carcinomatosis and he had a challenging nutrition status, so we did not use mitomycin. We started thalidomide, and after we started thalidomide in the third day, we started to see jaundice, and by the seventh day, there's evidence of liver injury. So we have to stop that. But I mean, because liver injury is never been reported in the literature of the side effect profiles. So we confirm that after we see this, we still cannot see the any literature report on the possible toxicity. We stopped the medication and everything came back. And so the patient went on with his original pathway along the cancer carcinomatosis. So I think the message here is that in addition to efficacy, potential efficacy, the real need here is that we really need a personalized toxicology screening platform. And so that when we came up with a treatment option, we need to verify its toxicity in the personal level rather than the general toxicity profile from the individual drug. So earlier this year, we looked back on the data we got, and we try to get something out of the statistic. We have the chemical sensitivity database. And then the way we do is that we decide to analyze the drug sensitivity and categorize their molecular action categories according to the cancer hallmarks. Originally, I was thinking that we will see one of the hallmark that will stand out as the tumor favorable profile, and that will be the Achilles tendon of the cancers, pan cancer wise. But it turns out that there's no specific dominant hallmark that will be a very a category enriched in cancer targeting. And the other thing is that we analyze the probability distribution of the drug sensitivity, and we found that those drug sensitivity, despite the cancer origin, all follow log normal distribution. So that is very similar to the bacteria sensitivity distribution to antibiotics. So I think in this sense, cancers and their response to chemicals follow the responses of bacteria to antibiotics. So we probably can borrow a lot of experiences when we are developing antibiotic therapies for infectious disease. And now we can try to borrow the insight and the experiences into cytotoxic or cell division targeting small molecules. So when we, as I mentioned earlier, we have some experiences with pediatric brain tumor, and we have a dominant surgeon in our university. He operates on 1/3 of the pediatric brain tumor in Taiwan. So he is very interested in the technology, and we worked for like 2 years up to now. And when he gave us the tumor sample, we tried to develop it into organoids, and we have that from all kinds of challenging brain tumors. And to mention that there's an Asian-specific pediatric brain tumor that is a germ cell tumor. Among them, there's a geminoma. There's no existing cell line, and we are one of the earliest groups that is able to derive a laboratory culturable system of geminoma that can be characterized functionally by genomic hypomethylation. And now we are studying the origin of radio resistance of those initially radio-sensitive tumors. And then, I didn't show it here, but I probably can mention that through the genomic and the pharmacology profiling approaches, now we are working on TGF-beta signaling pathway that may sensitize those refractory diseases to radiation, so that the kids may benefit from another round of radiation and combine with radiosensitizer. So sometimes when we phenotype, we think about viability, but there are more behavior than viability. So these are the cells we obtained from the pediatric brain tumor sample. This is a geminoma. They are quite homogeneous cell population. So when we grow them and observe under light microscopy, we can see them gradually cluster together into one big sphere. That is homotypic interaction we typically see with the cells. And now we see that with organoids. But if you look at the cell organoid derived from immature teratoma, we know they are quite heterogeneous, composed from all three different gene layers. So, I mean, along the course of 5 days, they remain small cluster moving around. They simply do not talk to each other. So these are all very interesting observations. And I think there are a lot of opportunities when we have this direct phenotypical observation from primary tumors cultures, either from the tumor itself or from the circulating tumor cell. And the more we know about the phenotypes, the more likely we can develop ASN tests to find out a good pharmaceutical treatment option. And with those, one of the example is that we explore the structure of the tumor organoid. This is the colorectal cancer in this case, and we realize that intra-organoid collagen is actually an interesting drug target. Not only it increases the stiffness and the structure integrity of the collagen as evidenced by damaged collagen stain. If you are able to damage the collagen, you will be able to sensitize the drug to cytotoxic treatment, either 5-FU or regorafenib by 2 orders in this organoid culture system. So, I mean, after we have done this study, I routinely treat my patients with pentoxifilin when they are receiving palliative radiation and they are having either regorafenib or 5-FU. Pentoxifilin is one of the agents we have seen with anti-collagen synthesis action, and there's no toxicity out of that, excepting 30% of patients may experience some GI upset. So my personal experiences in some of these patients is that the add-on of pentoxifilin stops the tumor from progression, gave them another drug holiday, and and I'm not sure about the progression-free survival extension because most of those patients after palliative radiation, they do not return to my clinic. And colorectal cancer, usually they are not referred to molecular tumor board because of lack of the actionable strategies. But in those few patients I have experiences, I do see something going on with pentoxifilin. So if there's any physician in the audience, we probably can share experience on this, and maybe we can start something together by adding this very low cost, very safely tolerated drugs to existing or colorectal cancer patients with refractory diseases. And in our laboratory, we are not only testing on cancer seeds, that is circulating tumor cells, we are also trying to develop in cancer models to test cancer soil. So by, like Stephen Paget said, that metastatic cancer is made of seed and soil. So after we have some experiences with modeling cancer seed, now we are trying to model cancer soil. And my collaborator, Fan Gangzhen, we developed several models together. And one of the interesting model is this appears very easy and simple setup. This is arginate hydrogel, and this is transwell, conventional transwell. And you can grow the stromal cell here. In this scenario, we do a osteoblast. We grow FOB cells upon here. And this arginate gel, for some reason, cancer cells growing in the bottom, there will be some cells with high stemness that will be enriched upon this arginate gel. And this enrichment process, I call it cell homing. And this cell homing process is a biological phenomenon, only happens in malignant cells, but not in benign cells. And it happens by biological modulation. You can modulate the stiffness of the gel or the biological chemoattractant composition in the upper chamber. And to make a long story short, with this system and with some validation, we try to screen for anti-metastatic agents with this chip. And we identify that AMD 3100 that blocks SDF1/CXCR4 pathway, that's the stem cell homing pathway, is interestingly effective in suppress the homing or the metastasis processes only in triple negative breast cancer, but not in lung cancer cell. So I think this is the proof of principle that if you have a cancer soil, you have another behavior assay, it is very likely you can repurpose some existing drugs for their anti-metastasis action, and that will serve as a adjunct treatment option in the personalized oncology domain. And another target we are working on is peritoneal seeding, as I show you with the gastric cancer gentleman. So in addition to cancer seed assay, we are also trying to develop some soil assay, and we have looked into the role of polymers and the presence of a polymer in the form of applicable gels in inhibiting metastasis. And we are also trying to do some endothelial components into the system, so that with the composite system, we will be able to test drugs targeting VEGF or angiogenesis pathway when the endothelial cells is in the system. And now we are doing the biological discovery assay along with the phase 2 clinical trial in gastric cancer. So one of the very interesting tumor soil is the lung. Because the lung is a very unique environment, there's a lot of airflow in that. So we collaborate with another professor, Tony Huang, also in National Tsinghua University. We try to use the lung chip to model the behavior of the tumor homing in the presence of oscillatory airflow. So I do not have too much to show here. It is just I want to show that we are trying to model the tumor in all the relevant physiological systems that has a chip available. And the cancer circulating tumor cell is not only a biomarker. It can also mean it can do much more than that. In this example, we are trying to use the circulating tumor cell derived organoids as a cancer vaccine. So Dr. Jack Hu in Academia Sinica, Taiwan, developed a process that can immobilize the surface proteome and allow the cell to be processed to be stored indefinitely in room temperature. And this chemically modified circulating tumor cell, originally he was thinking about doing something else. But then I convinced him that it sounds to be a perfect process for us to generate a tumor vaccine. So we do adaptive cell therapy in mice, and it worked perfectly well. And the mice being vaccinated with this CTC-derived organoid chemically modification, and they develop a very specific anti-tumor immunity, and the tumor did not recur in several different models. And this process also happened in human relevant cells. Of course, we cannot do adaptive cell therapy with this cancer vaccine approach, but we can stimulate tumor-specific immunity in deficient AMR, in colorectal cancer patients with deficient AMR. You can stimulate the peripheral biomolecular cells with this chemically modified CTC alone, without the need of antigen-presenting cells, and you can trigger them to produce interferon gamma. And these are the patients who is going to respond to anti-PD-1. So I think with this system, we will have another platform that will be able to predict the outcome of anti-PD-1 treatment in this challenging population of colorectal cancer patients, in addition to the genomic marker of deficient mismatch repair. So I want to wrap up the talk by quoting Dr. Ignatiadis from University of Leiden in Belgium, in Brussels, in Belgium, that when you want to develop a liquid biopsy assay, the most important thing is to start clinical usefulness early, rather than setting up a certified lab and then come back to prove this. I think there's a whole lot of rationale, and Dr. Ignatiadis mentioned, and you can refer to this Nature Review Clinical Oncology paper. But from our journey of developing these liquid biopsy assays, I think establishing clinical usefulness and from clinical patient sample is of utmost importance, and it has to be done upfront before anything can be moved on further. So I have a lot of help. I have obtained a lot of help from Taipei Medical University Health Safety System and also other universities throughout Taiwan, both in technology development from National Taiwan University of Science Technology, National Tsinghua University, and Academia Sinica, and also clinical collaboration from Chang'an and Veterinary General Hospital, Taipei and Kaohsiung in Taiwan. But I think the most important help comes from this patient. They are willing to spend their anti-cancer journey with me, and we fight together trying to explore the limit and the possibility of cancer treatment in the tertiary setting. Hopefully, with collaboration between us, we will be able to move it, scale it up, and move it to the secondary setting so that we can help decrease the cancer burden in the personalized cancer era. So this is all my talk. Thank you very much.
Thank you, Long-Sheng. That was great and covered a lot of interesting applications for and diverse areas. We'll open it up now to questions. I don't know if any members of the audience wanted to unmute and ask a question.
I have a question. That was very interesting, yes. Professor Liu. So it seems that some of these organoids can be grown over time. Have you ever examined changes in their drug sensitivity profile at early time points versus later time points?
Yes, I mean, in the case of the Grace fibromatosis, I mentioned very early on in the talk, we actually, because she regularly came back, so we were able to sample her organoid at 2 different times. So we do see the drug sensitivity evolves. In her case, the drug, her organoids became resistant to many of the chemotherapeutics, although she was never exposed to any of them. But her organoids remains responsive to tamoxifen, and which corresponds to her clinical behavior. So yes, pharmaceutical behavior do change along the time. Response to anti-cancer drug do change after they are exposed to certain cancer drugs. We are not sure about the collateral changes that happen. We do not have a plan to systemically examine the hypothesis. We know that change genomically, but phenotypically we have no systemic data examining the hypothesis.
So just to be clear, I was asking the slightly different question that, like, if you took this same organoid or the same ex vivo culture and exposed it to a panel of drugs at an early time point and repeated and subjected it to the same testing at a later time point, have you compared those?
They are the same. Yes, we have done that. Actually, that is a basis for us to decrease the time in our process. Our original process takes 6 weeks for us to get the reliable results. And recently, we are able to successfully shorten that to 3 weeks. That is because we shortened the culture period and we shortened the antibiotics test area, and we also improve the technology of counting so that, and we validate the faster version of process to the older version of process, and they predict the response equally well. So we are confidently decrease that process to 3 weeks. So yes, with the same sample in the same culture period, the drug sensitivity they are the same. Numerically, there will be probably variations, but the trend, whether or not they will predict, the treatment outcome, the number below or above certain threshold, that's the same.
I had a quick question. I think it's
yes.
An impressive demonstration of how our technologies now enabled us to look at very few cells. Maybe if you could speak a little bit about the total absolute number of cells which are used in a standard assay to represent the patient's giant tumor population. And then also, have you looked at high resolution microscopy on those spheroids and how they evolve, and do they contain like immune cells, which may be probably from the blood, but do you have like a built-in immune component like many early organoids grown ex vivo?
So those are very nice questions. Actually, we are working on that. So some of the key information I can share with you is that numerically, we know each organoid contains, the organoid we have contains roughly anywhere between 100 to 300 cells. Interesting enough, if you get the organoid from blood, they always stop by certain size, then divide, just like we have the stem cell culture. But you get it from the tumor, the primary tumor. Sometimes they just keep growing to a very big size until there is a core necrosis and hypoxia. So I think that there's a difference between cancer stem cell and the primary tumor cell. And in terms of number, we do not routinely increase. I think we have this conversation very early on. So routinely, we do not have the counting incorporated into our system because we need every single drop of the blood to submit them for amplification for organoid production. But now in the clinical scenario, we are considering to have a accompanied tumor count assay as a add-on. So the tumor count certainly, yes, we will say more tumor. We always have very good success with small cell lung cancer. So the more circulating tumor cell number, you have a more organoid. I'm very confident about that. But I mean, we do not have the linear correlation data of that specific outcome. And you mentioned something very interesting. What's the spatial geometry of those organoids? And Professor Wong, we actually have some paraffin session demonstrated certain degree of the neural organoid formation with that tumor-derived organoids. And now we finally we have some resources. We can do spatial genomics, and we are working on that. We dedicated resources to pediatric oncology, to pediatric brain tumor. Hopefully, we will be able to elucidate the tumor components inside each organoids. And very, very early on, when we are developing the technology, we try to deplete each lineage of the white blood cells and to see if there is a specific lineage of white blood cell or immune cells that is important in organoid formation. And this has never been published, but I mean, we found out that when we deplete neutrophil or granulocytes, the formation of the tumor organoid drops significantly. I don't really know what neutrophil do in promoting organoid formation. We have some other data. Neutrophil may have some antigen presentation capability, but I don't think that has any relevance to organoid formation. So, I mean, if you are interested in that, we can work together to try to figure out.
That's great. Other questions? If not, then we'll go ahead and end there at time. And thanks so much for your presentation. Really exciting to see what you can get from a liquid biopsy in this arena.
All right, thank you, Keith, and thank you, everyone. So thank you for inviting me here.
Take care.
Thank you, bye.